Mr. Chairman, ladies and gentlemen, good morning. This is a very difficult topic, what candidates require surgery in back pain cases. Now, back pain surgical option is a dilemma as far as the surgeon is concerned to find a proper indication and type of surgical treatment, and overall to prognosticate the outcomes of surgery. What are the indications of the surgery? Degenerative disc disease, which is not responding to a conservative therapy for more than 6 months. One should have tried conscientious conservative treatment for 6 months before opting for any surgical intervention. Instabilities are the most common cause of, most common indication for surgery. These are the spondylolysis, spondylolisthesis, degenerative scoliosis, or somebody develops neurological symptoms like radiculopathy, Corda-Equina syndrome, and then there is infection, tumor, and osteoporotic fractures. How will you evaluate a patient for surgery? Clinical evaluation, a thorough clinical history is required, a proper clinical examination, and above all, psychosocial assessments of the patient should be done. Because many of the patients will have psychosocial factors involving the backache, and somebody if operates, the patient will be after his blood. He will not recover. So then you have imaging studies. You can take the help of imaging studies. Plain radiography is very important. CT scan, MRI, and bone scan in indicated cases. So imaging, plain radiography, standard AP and lateral views. The most important is a flexion and extension views to evaluate the instability or mechanical problem in the back. So oblique views can show you spondylolysis or defect in the pars, and you can see the sacroiliac joints also. CT scan, you can delineate better the bone lesions. The MRI is very important. Now, this is a black disc. The patient is having back pain. How will we say that this black disc is causing the back pain? It is very difficult, because 45% or 60% of the patients will have black discs which are asymptomatic. You will just find an MRI that they have multiple black discs and they have no symptoms at all. So how will you correlate this black disc when you are operating? You will have to take a proper history. You will have to find out whether the patient is having a mechanical back pain, and then you will have to do a provocative discography. Provocative discography, the role is questionable. Now what we do is we take this involved level and we put a needle in the normal level, one above and one below, and then we inject a dye. A normal disc will take about a cc of the dye, and it will never leak outside. A disc which is degenerated like this, the dye will leak out everywhere, and the patient will have concordant pain. When you are injecting under pressure, patient will feel the same pain as he was experiencing before. So that means you can correlate somehow this degenerated disc to the pain of the patient. Now, what are the type of surgeries you can do in a degenerative disc disease? You can do a fusion surgery, which can be anterior and posterior. You can do a non-fusion surgery, which can be, again, anterior and posterior. Now, this is a case, 44-year-old dentist, low back pain 1 year, leg pain 1 month, L4-5 tender, SLR 10 degrees, and EHL 3/5. And you can see there is a narrowing of the disc space here in L4 and L5 here. And this is the MRI. You can see a degenerative disc with a small protrusion on the back, compressing the root. And this was managed by a plain discectomy and DIAM. DIAM is an interspinous spacer. Here, we want to put this spacer here in between the two spinous processes, so that when the patient is loading, he is not loading the facets, he will be loading his disc. So you want to take away the loads from the facet joints and put it on the discs, and thereby relieving the back pain. Now you can do a disc replacement in selected cases where you attribute the back pain to the disc degeneration. This is one case where we have done disc replacement in L5S1. So this is a non-fusion surgery, and here you can maintain the movements and you can avoid what is called an adjacent level disease. If you do a fusion here, the whole loads are falling here, and ultimately this level is going to get degenerated and will lead to back pain again. So you can do a non-fusion surgery like a disc replacement, where you can have the movements which mimic the natural movements and can avoid adjacent level disc disease. Now, this is a case where you have a degenerated disc which we have fused from posterior with the pedicle screws and a interbody cage where we have put bone grafts, and this is 3 years follow-up. You can see the fusion is solid here, and there is no back pain. The patient is without back pain now. And this is another case where we have done fusion from the front. This is another L5S1 fusion for a disc degeneration, where we have put a cage which is standalone cage. You don't require anything else from the back. So you can avoid problems while you are doing from the back surgery. Now, the other indications for surgery are discitis or osteomyelitis, which can be tubercular or non-tubercular. This is one case, 58-year-old females had recurrent UTI, diabetes, and pyogenic osteomyelitis L4-5. Now here we have debrided the level from posterior and fixed it with the pedicle screws and put bone grafts so that it fuses it, and IV antibiotics. This is another case of tuberculosis, 68-year-old male with neurological problem. And so this is, we have done debridement and decompression and fixation and fusion. And another indication is spondylolysis and spondylolisthesis. This is a mechanical problem, and you can see spondylolisthesis here with a pars defect. This is the MRI, and this is the fusion, anterior and posterior, which we have done. Tumors and metastasis. Tumors and metastasis, the treatment is chemotherapy or radiotherapy, but when you develop fractures, they become a mechanical instability in the spine. So in those cases, we can help by, this is one fracture in multiple myeloma, this is another fracture in multiple myeloma, and you can see we have done a percutaneous kyphoplasty, where we inject bone cement into the vertebra after you balloon it out and maintain the height, and you put bone cement. So once the bone cement sets into this vertebra, it provides the mechanical strength. So another indication is hemangioma. This is an hemangioma where we have done kyphoplasty. We have put percutaneous. We have done percutaneous kyphoplasty. You can see the lot of cement occupying the whole of the vertebra, and it gives you mechanical strength. Then another big indication now is coming up is osteoporotic compression fractures. So any old age, you develop osteoporotic compression fractures. They are mechanical problems. The patient is not able to get up, and this is kyphoplasty, which we have done. This is another case of osteoporotic fracture managed surgically by anterior and posterior because he has developed a neurological deficit. Another one, you can see there is a collapse here. There is another collapse here. And this is what we have done, kyphoplasty lower in L4 and a decompression anterior posterior up. Lumbar degenerative scoliosis, these are cases where patient is not able to sit, walk, stand because of severe pain in the back and radiation of the pain in the lower limbs. This is the MRI, and this is, you can see this fixation, and we have maintained a balance on coronal as well as the sagittal planes. Post-tubercle kyphosis, severe back pain, is not able to move, and this is after the correction. You can see the balance. So these are the indications of surgery in back pain patients. So to find a proper candidate for surgical treatment of lower back pain is very difficult, and favorable results are not more than 80%, even if you select them properly, particularly in those cases of degenerative disc disease. Kyphoplasty has revolutionized the treatment of pathological osteoporotic fractures. Open surgery with various instrumentation can take care of major instabilities and deformities in back pain patients. Thank you.